All right, welcome everybody. So glad to be back with you on this Sunday evening and those who are watching during the week on Zoom. Thank you to everybody who sent in your questions during the week. We have a lot to cover this evening with our host, Glenn Grossman, who is an epidemiologist with over 20 years of experience. While pursuing his doctorate in epidemiology at UNC Chapel Hill, Glenn served as an epidemiologist on staff at the UNC Infectious Disease Clinic for 2 years, and he taught epidemiology and advanced analytics at Duke Medical School and at UNC. He has been involved in epidemiology projects with Medicare, Medicaid, Veterans Health Administration, Military Health Service, CDC, and other programs in the United States and abroad. He is currently Senior Director of Outcomes Research and Epidemiology at Novartis, but all views expressed today are his own. So again, welcome. Wanted to take you through some of the topics we'll be covering tonight. We'll be talking about climate, diabetes, mouthwash, remdesivir, and family gatherings. Those are just some of the topics we'll be covering. But before we jump into the details, Glenn, please take us around the country and around the world. What is going on?
Thanks, Rebecca. Good to hear from you and everyone else, but thank you in particular, Rebecca, for co-hosting every week. So let me share my screen. All right, I need to go up here. Share screen. Okay, great. So as we talked about last week, the numbers have started to rise almost across the United States at this point. So as we expected, we're in the third surge. We've entered the typical cold and flu season. So when respiratory illnesses can really start surging typically in a year. So now we're in it. So now this is the beginning of what will likely be a few months of a really challenging time. In the Southern Hemisphere, they just left their winter a couple months ago, and down there for many countries, their experience was like it was like COVID-19 on steroids. So that's what we're expecting, that it's going to get much more challenging. I can share with you a couple of things to look at. First, here you can see where the spread is happening now in the United States. It's not hitting every state all at once. Instead, it is, you see some states that never managed to fully deal with it well are really spiking right now. So in particular, if you look at North Dakota and South Dakota, those numbers are huge. This is 1,000, so North Dakota, 1,164 per million people. The reason I'm presenting that is Florida at its peak only hit around, it says 712 on that one day, but that was just a fluke that one day. On average, I think the peak was closer to around 600, a little bit more than 600. And so you see how bad things are already starting to get in North Dakota, South Dakota. The weather has shifted and people are spending more time indoors, and this is what much of the country is likely to look like in the next couple of months. What we're looking at in particular, I wanted to show you, let me just put this on pause. All right, Rebecca, can you please put it back on mute all? Thanks. All right, so what we're looking at here is the United States at the national level. And so what you see here at the national level, luckily we've been getting better at doing more testing, but unfortunately you can see where we're at with cases. We had the first surge, then the second surge, which went down a little bit, but now we're at the third surge, and we've hit over 80,000 cases per day, which we haven't seen before. And so you can see that the 7-week average is already, or rather the 7-day average, the weekly average has already exceeded our second surge a few months ago. The hospitalization rate is delayed, as you can imagine, after the cases have started to surge. The second surge hit a few months after the first one. The third one, we've just begun to see the climb in hospitalizations, and it's very likely for a variety of reasons that our hospitalization rate in the next couple of months is going to far exceed the hospitalization rate that we saw in the previous two surges. The death rate and we might be able to get into this a little bit later, the death rate from the first one to the second one went down dramatically for two reasons, or three reasons. The three main reasons were: one, the people who got sick tended to be much younger across the United States, and so the younger you are, the less risk of severe disease or death. Two, the summer seemed to have a huge impact in terms of preventing both infectivity and also severity of the disease, because typically we know that the higher the dose of initial exposure of the infection, the more the immune system has to ramp up to address it. And it's that rapid immune system that typically overshoots, and that's what makes it such severe symptoms for a lot of people. And so we're still trying to figure that out. And then the third thing is that the medications and treatments have gotten a lot better. And so now the problem is that what we expect in the next surge is that the treatments are going to stay the same, because there's nothing new that's going to be released in a widespread manner within the next month or two. But what's going to change is that because of the seasonality, it's going to become much more contagious as a virus, because people are going to be spending more time indoors. The R value, the effective R, is going to go up, which we're already starting to see. And that means that the initial dose of exposure is going to start to rise again. And then also the people who are infected are less likely to be the younger. It's good. People will have more of an equal opportunity of getting infected as we go forward. So it's likely to be that some of the estimates that I've seen are that we're likely to begin seeing over 2,000 deaths a day by sometime in January or February. So reaching that level again. All right, so let's see. There is a little bit of uncertainty in the models, though, and that is largely driven by our behavior. If we have way more widespread mask wearing, so say there's a mandate at the national level and the state levels that everyone is required to wear masks, and there's penalties if people don't wear masks, then that would make a huge difference, and it would be less likely to hit the 2,000 per day mark. But if we continue on the direction that we're going, where people like to have big get-togethers on the White House front lawn, then you're going to continue to see big issues. Oops, let me see if I can do something. Is there a waiting room? Becca, I'm not sure how to change that. All right, let me go on to different regions, but it is impacting regions differently. So you see that the numbers are jumping, but let's look at different regions. So the Midwest is getting hit really hard, and so you can see the caseload is going up dramatically. And so the caseload is here currently hospitalized in the Midwest is also rising dramatically, and the death rates are going to follow. But it has a way to go. You can see that the currently hospitalized is pretty high. So we can see what the future is going to look like there. With the Northeast, so the testing has gotten a lot better over the months. We're in much better shape for testing, but unfortunately, we can see that the cases are starting to go up. Whereas we were doing pretty well in the summer when it was easier to keep it down. Now that the weather has shifted in the Northeast and we've had more cold days and nights, the caseload is starting to go up. The effective R is going up. And so we're also starting to see an increase in hospitalization, and then the death rate, even though it's still pretty small relative to where it was, we'd see a definite trend that it's increasing. We're on our way. In addition, if you look at some other areas, so if you look at the South, So the South really had its big peak earlier in the summer. Then it stopped going down. The cases have started rising again. The cases in the most recent days have started rising dramatically. And within a couple of weeks, we'll be at where we were at the peak during the summer. Hospitalization is starting to increase, but there's a delay between when we start seeing these rapid rises in cases and the rise in hospitalizations. And the death rate in the South is not demonstrated. It takes a while between the hospitalization starting to rise and the death rate starting to rise, but that's going to come as well. And then in the West, um, this is something that was interesting too. So some people say, well, how long does it take between the diagnosis of the cases rising, then the diagnoses of the hospitalization or the hospitalization rising, and then the deaths rising? And it's harder to say because the problem is that the cases rise in different places. If it's rising in one place, then the hospitalization rate might not be the same because it depends on how diverse and widespread it's occurring and who the people are that are getting sick in terms of their risk factors. Let's see, in terms of, and so let me show you this. Let me put this on pause again. So there's a few things. First, I wanted to show you this. So let's see. So the diagnosis rates have been going up. And so you can see in the beginning of the year, back in March, April, red is the number of cases that are diagnosed, and blue is currently hospitalized. So you see that there were more people hospitalized that we realized afterwards had COVID-19 versus people who actually were diagnosed with cases early on. By the summer, when we saw the peak happen again, it was roughly on parity where cases and hospitalizations were roughly the same. And now as we're going into the new surge, the diagnoses are happening at a much faster rate than the hospitalizations. So we are getting better at diagnosing. I was looking at some other interesting factors here. So if you look at the currently hospitalized, back in March, nationally, it rose really rapidly. And if you look at that same slope, so I took the arrow, you can see that the second surge was not rising nearly as rapidly. And so if you look at this third surge, the green arrows are the same slope. And you see that the third surge is happening at roughly the same speed as the second surge. So the big question is, how big is the third surge going to get? And the main difference between the second surge and the third surge was that the second surge was localized to just a few states. And so let me go back here for a second. So, so if you look regionally, you can see that in the South and the West, that's really where that second surge was mostly taking place. But now in the third surge, it's taking place everywhere. We're seeing it in the West, in the South, in the Midwest, and the Northeast. And so as a result, it all adds on top of each other. And so it's going to be much, much harder to bring it down. This was the peak in the South in the summer. And the summer was the time when the virus was the least contagious. So now it's gonna be a challenge. We're gonna see as in the winter months that it's gonna get more challenging. In addition, all right, I showed this curve. What else did I want to show here? So I showed regional, I showed daily. We can look at at some of the specifics. Let's go to in the United States. So now this is the effective R value. So let's take an example. We knew so let's go to New Jersey, where I live. So New Jersey, when back in March and April, so let's say this is late February, March, the R value was around 4. So globally, the R value was estimated to be around 2 to 3 or so. But based on the number of people hospitalized and the deaths and our retrospective analysis, our best estimate is that in New Jersey, given the density of the population and our habits in terms of how much commingling we did regularly before the outbreak, our best estimate is that it was around 4 in New Jersey. And so we got it down after, but after the shutdown in New Jersey, we got the R value very low. But then it slowly went back up. Over the summer, it stayed pretty low, got a little bit higher, but now it's gone up to 1.3, which means that it's spreading. Currently, New Jersey is the slope of increase is the most in New Jersey than anywhere else in the country. If you see here, this is what we just looked at. So here, New Jersey is not doing the worst right now. New Jersey is doing okay in terms of how many actual cases we have. What's different is that these are the absolute number of cases. And so right now, the state doing the worst is South Dakota on a normalized basis in terms of like all things being equal, if you normalize the size of the populations. But New Jersey isn't doing so bad relative to that right now. But when we look at the slope, this tells us who's accelerating towards getting more infections more quickly. And New Jersey is accelerating the fastest right now. And right now, it's only going to get harder and harder to get it under control in New Jersey. And I mean, people need to be wearing masks and be doing more. But I mean, frankly, there's a lot of exhaustion, I think, from COVID-19, and I don't think people perceive that the spread is happening and that we could be in trouble in another month or two, given the rate that we're going right now. And so that's where we are here. You can see that there's a lot of almost all states in the country are now the virus is spreading again in too much. The only states right now that are doing okay are Missouri in terms of the direction of how many people are getting infected, are Maine, Florida, and Mississippi. But the problem is that when you look at the states themselves, they're still not out of the woods in terms of the total numbers of people. So it's still uncontrolled in many of these places. There's no place in the country that I really say has it under control right now. Possibly Maine, that we just saw that our number is low, but Mississippi, yeah, I don't know. This week it's going to be a really tough next few months until, let's say, March or so. All right, if you look globally, this is one thing that's really interesting to compare. So the European Union, their average right now per million, so that's the good way of looking at this is to compare all populations per million, because then it is an apples to apples comparison across all geographies. So in Europe, it's around 275. European Union is 333. That compares to the United States. You can see where we have North Dakota 1100, South Dakota 1200. So if South Dakota was its own country, South Dakota would be one of the worst countries in the world. And so that's one of the things that we've been talking about with the United States is that even though at a national level, when you compare to the United States to other countries, our totals never really got super high relative to other countries. But that was hiding the fact that the individual states were getting really high, but were just peaking at different times. So so now, because all the states are now increasing at the same time, the United States is going to start to get some big numbers. Right now, let's see where we are. So right now, we're not doing so poorly at a national level because we have a lot of states that are not reporting very many. We have some low numbers here, but you saw that these are all going to be increasing. So our numbers are going to go up. And so that's what it is. I'll just see if there's anything else. You can see the dashboards. I'm not going to go into detail here in terms of but they're all red and dark red, except for a couple of states that are still have managed to avoid things so far. In terms of, oops. This is testing and contact tracing. You see that we're really in bad shape. We're entering the season. It didn't need to be this way. If we had had a bigger investment and bigger commitment in contact tracing, we could have really, and testing, we could have avoided this. You see that some states are doing well. There's a bunch of states that are blue. And these states that are dark red, it was a choice for them to not invest in the contact tracing and the testing. And that's what they get. If you look at some other things, this dashboard, it looks at some slightly different metrics. This focuses more on the county level. Um, and I think that's enough for now. We can start, unless there's particular questions a little bit later. Let's go into the specific questions that people had.
Okay. Thank you, Glenn. Yes, we have a lot of questions that came in during the week. So we'll jump to that. Specifically, Harry has a question regarding the data and the reliability of the data. So Harry, I will ask you to unmute. Oh, you already did. Look at that.
So the question that I have is, with the Trump administration doing what they're doing, how confident are you in the data that you're getting, that you're doing the statistical evaluation on?
Yeah, so because there was a challenge in getting data, one of the things that was new with this administration, so the CDC, as I've been mentioning in previous weeks, used to be one of the, or not used to, not one of the, the US CDC was the single best center for disease control in the world. Other countries saw the US CDC and tried to replicate it just because ours was the #1 in the world, and people would beg to have a position there for a period of time so that they could take learnings that they had at the US CDC and go back. From previous epidemics, one of the key insights that the US CDC found and published was that the most critical factor for success in dealing with an epidemic is transparent communication. Frequent communication, consistent communication, reliable, but above all, transparent. And with the Trump administration, what they've come in, and again, not to make it political, just to say what's happened. Right now, the CDC has reprioritized and no longer puts communication as a top success factor in terms of what they are committed to. So, for instance, we all know in terms of the public who the head of, like in terms of epidemiology, we've all heard the term Fauci. We've all seen Fauci on TV and whatnot. But I've asked a lot of people, who's the head of the CDC? And almost everyone I ask who's not epidemiologist, almost no one knows. We're in the middle of the largest epidemic in the United States in a century, and almost no one knows who's heading up the CDC in the United States right now. I just find this astonishing. It's Robert Redfield, but he's been incommunicado for most of the public, and most people have no idea who he is. So I mean, but in addition to that, getting back to your question, the CDC has not been releasing a lot of data. Some of the data they had to release because they were sued by organizations to release it under the laws that require public access to some government data. But there's still a lot of data that's not being released. And as epidemiologists, it makes it a challenge when our best practice that we've known for years, when our US CDC used to be the best in the world, was that transparent, reliable, valid communication is critical. And so the fact that they're not doing it, it's for us is a clear signal of what's going on there. But there are data from other sources. So a lot of these data feeds, in terms of what I show you, are gotten not from the CDC, but directly from other sources. So there's networks of hospitals that report the data. Some of the data is available on the CDC's website. There are other sources that people go to. For some of the lab testing results, the web organizations are going directly to the labs to get the results from them. And so the data we do have a lot more confidence in. That the data I show you are from specific websites that I feel have been validated, that those are the best sources of data that we have right now. And so, because there's a lot of different sources out there, and the ones that I have, that I use, I rely on the most. The COVID tracking project is one you see a lot that I have a lot of trust in, just because I've looked at the rigor with which they're collecting the data and validating it, and it's among the best that I've seen. And they're as concerned as at least as anyone else, trying to ensure that the data that they receive is valid and checking it and cross-checking it with other sources. But having said that, so there was just in the news, I didn't do a clip in Florida this past week. The government of Florida decided that they don't trust the CDC diagnostics of the people who are dying from COVID-19. And it's fair to worry about the integrity of data is a legitimate concern that everyone should be worried about. But the problem here is that it's a political motivation, and what's driving it is not anything to do with data integrity. It's that Florida is concerned that they're looking worse than they feel that they should be looking based on their policies, because there have been a lot of deaths from COVID-19 in Florida. And so the crazy thing is, and the way you can tell what they're doing is politicized rather than focused on data integrity, is all they care about is looking at the false positive rate. So they're digging into the data and they want to be very sure that the people who died, that were diagnosed with COVID-19 as they died, were really COVID-19. And the vast majority would be. But a lot of the primary care physicians are the ones reporting that, and there's a delay, sometimes of months, before it gets into the systems. And so that is what it is. The problem is a lot of people who die from COVID-19, as we've seen over the months across the United States, are false negatives. So they might be having blood clots or other things that form sometimes weeks after the infection. And so the person might die of a heart attack, stroke, or another indication, another disease, but then they are not recorded as a COVID-19 death. That's why we have to look at the excess deaths to try to figure out if it was truly a COVID-19 death or if it was something else. And so in Florida, we are seeing a lot of deaths, and a lot of them are false negatives. So when you hear about what the Florida government is doing, for instance, they're almost certainly not trying to validate any of the false negatives. And so it's problematic. All right, next question, Rebecca.
We're all very lucky that we have you, Glenn, to take us directly to the validated data. So thank you, and then help to parse it down for us. So last week we spoke about humidity, and you spoke about the value of having a humidifier in the room and how that helps slow the transmission, or I guess the aerosols, the particles in the air. So do we know more about why the disease severity, this is the question, decreased during the summer? And then the follow-up question is, will COVID-19 severity increase in the winter?
Yeah, that's a really good question. So just to dig back in for 1 second about the humidity question, if I can pull it up. So I should just say, so we have to be careful in terms of interpreting the humidity that I talked about. So I'm not going to go back into that. But basically, the humidity has a strong correlation. And we found that in places where there was more humidity, there was less spread. And so that correlation was strong. And so because of that correlation, that's the reason that we were thinking, well, it might be a good idea to increase the humidity and use humidifiers and whatnot inside. However, I don't think I've seen any clinical trial that's put a humidifier into a home and seen if there's less SARS-CoV-2 transmission as a result of that intervention. So it's one of these things where it's not validated with a clinical trial, but because it's likely to have an impact and there's not a risk of putting a humidifier in, it's a good thing to think about as a possibility of using during the winter months to not have it dry air as much. But let me go into this question about the case fatality rate. So the first thing is, we'll notice across the world, across much of the world, during the summer that we had, you can see that the case fatality rate was going down dramatically. So in Europe, it was going down. In North America, it went down. In Asia, it went down. But let's look, in Africa, it went up a little bit. And that's curious. Why was it going down and then went up? And so let's dig into this a little bit more. So in Africa, what you see here, let's just, for people who might not look at a map very often. So here is the equator line. So a lot of these countries are near the equator. So I was looking more, I decided to focus more on the countries that were further away from the equator, so further south, because for them, winter would be more pronounced in terms of what it would look like. And so in particular, here, let me look at it this way. So here's Zimbabwe, there's Zimbabwe, South Africa, then Namibia, Mozambique. And so you can see, like Botswana, you can see that in Africa, there was a remarkable increase in the case fatality rate over time. So now this is not telling us how much it spread or how many people got sick. This is saying for each person who got sick on average, how severe was the disease likely to be and how many people were likely to die from it. And you can see in their winter, so our summer was their winter, there was dramatic increase in case fatality rates. So this was Africa. Let's look in other places. So here's South America. And here again, I need to bring to front. Here again is the equator line. And so you can see that it would be more interesting to see some of these countries that are a little further away, because that means that they have more dramatic effects for winter. But what we're looking at here is Bolivia. So it's still not too far from the equator, but Bolivia had a marked increase. Peru, which is closer to the equator, so less impacted by winter weather, went down. So I would mostly ignore that. Chile was mostly flat, so that's interesting. But Chile extends really far. There were parts that were further north and parts that were further south. So the experience of winter varies a lot in Chile, and I didn't dig in to see within Chile how it varied. Argentina, where a lot of the country is further south, so they have more pronounced winters. Argentina did go up. You can see a bump up that it had. Paraguay also went up during their winter months. So again, South America, the story is consistent with what their experience was. Australia is interesting for a bunch of reasons, but the big takeaway here is that the case fatality rate increased by it tripled essentially between its low early in its winter, so which like early July to October, the case fatality rate tripled. So this is really, when you look at the Southern Hemisphere, it's really not looking looking good for us in terms of what our Northern Hemisphere winter is going to look like. What I did is I wanted to look to see how far away from the equator these countries were. So we were looking at Paraguay, we were looking at, so the distance between Paraguay, if you were to go up, is kind of like Southern Florida in terms of the increase that Paraguay saw. South Africa, if you were to go up, the increase, that brings you to like Egypt, like maybe almost Israel over here. And so that means that we don't really have many people living down here. So our winters are going to be far worse than the winters experienced in South Africa and in South America and Australia. In Australia, if you look down here in terms of the distance between Australia up here, you can see that this is still pretty far south. So when we're looking here what the experience of the winter months are going to be, much of the world's population is living in the Northern Hemisphere. And among those who live in the Northern Hemisphere, a lot of us are living pretty far north. So we're going to get hit hard by the winter. And so what we saw was this early signal that the countries furthest south, furthest impacted by the winter, were hit really hard. Again, Australia, their case fatality rate tripled between their summer and their winter. And so if our case fatality rate were to triple, that is not going to be a happy winter for us. Things could get pretty bad. And that's in part why some of these models are suggesting that we might go back to seeing over 2,000 deaths a day by January or February. Here's together the countries that were lowest or were further away, not lowest. You can see I have a northern mentality where on the globe, the northern hemisphere is on top and the southern hemisphere is on bottom, whereas on the southern hemisphere, they see themselves as on top because everyone's on top wherever they stand. But so the furthest away from the equator in the southern hemisphere, when you look at just those countries in particular, you see consistently they all increased over the winter. So it's very likely. The one interesting thing here to point out, let me put this on pause for 1 second. The one interesting thing is when you look, that's not what I want. Let me go back up here. When you look over here, so this is Northern Hemisphere. Again, this is Europe that we're looking at. The numbers went down and they were all ending up right around 2 or 3%. And in the Southern Hemisphere, when they increased to around 3 or 4%. So I don't know whether our numbers in the Northern Hemisphere are going to go up again, or whether they'll stay roughly where they are at 3 to 4%. Some of these countries are likely to go up again, but it's hard to know yet until what that looks like. But the fact that in the Southern Hemisphere we saw such dramatic increases in the case fatality rate makes it a leading hypothesis that our case fatality rate will go up again in the Northern Hemisphere. One other thing to point out here, let me just go back real quickly. All right, so one other thing to point out here was there have been a few studies now looking at the infection fatality rate over the summer and why it dropped so much, because it dropped dramatically over the summer versus March, April. So this study was from New York. I previously showed you a study, I think, from Texas. There have been some studies in Europe that were published. This one in New York was really interesting. It showed it that the blue line was the actual number of the actual death rate coming from the hospital among people with COVID-19. So it went from around almost a third of the people who got into the hospital for COVID-19. I don't know if this was the ICU or just the hospital at large. I think it was the hospital at large, but let's just, whatever it was, it went from around a third to around 7 or 8%. And so that was a huge, huge decrease. And so it wasn't clear what the primary motivation, what the primary driver of that was. And it seems like the three contenders were: one, the patients were either younger or older, like, so they might have been a lot younger in the summer. Two, the seasonality thing, where I just talked about the case fatality rate going down in the summer. And then three, the drug treatments. And when you look at this table, let me see if I can make it bigger. Bring to front. So what we saw actually was that the age range, the median age range, the average age range in March was 67 in that New York hospital. But then the average age range in June was only 49. And we know that the age makes a huge difference in the risk. And so one of the strongest reasons that the case fatality rate dropped so much was that the people getting infected were a lot younger in the summer. They were the ones going outdoors and hanging out with their friends, and so the ages of these patients were much lower. But then, in addition to that, there were incremental improvements, and also the seasonal variation that we just talked about. But then there were these real improvements in clinical experience. So there was growing use of new pharmacological treatments such as the corticosteroids, remdesivir, other anti-cytokine treatments. There were proning, so putting people on their stomach was found to be helpful. Earlier intervention, community awareness, all of these things together had a huge impact. And this is what we see in terms of the dramatic decrease over the summer. Some of these things are going to remain. So our new knowledge on how to treat people is we have that now. So because of that, the infection fatality rate is going to be lower now versus what it was in March. But it's going to be more contagious. That means the dose that a lot of people are going to have at the initial infection is going to start to increase. And so we're going to see a lot more severe cases that go on, and older people are going to get it as well. All right, back to you, Rebecca.
Thank you, Glenn. Very interesting. I used to prefer when we would talk about the slope of the ski hill and not these slopes, but yeah. Nevertheless, we do appreciate you taking us up and down these different slopes. So you talked about the different treatments and how we have a lot of knowledge that's been amassed over the last few months here and abroad. There's been conflicting news about remdesivir over the last couple of weeks. What do we know? Is remdesivir safe, and is it effective?
Yes, so that's a really challenging question. So at this point, it's interesting. So October 15th, almost 2 weeks ago now, the World Health Organization published its early review of its early trial results. So the trial has ended, and so this is sort of like a draft of the final paper. And it published the results, And the results were clear that remdesivir was not effective at, at helping people with COVID-19. It didn't reduce death rates. It didn't reduce length of stay. It wasn't useful. They looked at a bunch of other drugs, including hydroxychloroquine, which we already saw tremendous evidence demonstrating that that was not effective, lopinavir, interferon, and they didn't, when they looked at all of these, they had separate arms looking at all of them, and none of them were effective. But then the FDA a week later decided to approve remdesivir. Previously, remdesivir was available under the emergency use authorization, which is when you think it's more likely than not that a drug will ultimately be shown to be effective and safe, but it wasn't actually approved as just for regular prescribing by physicians. What the FDA did on October 22nd is they made it so remdesivir could be prescribed just on a regular by a regular physician. And the data that they used must not have included the data from the World Health Organization, because if they had, they would almost certainly not have made the remdesivir available for COVID-19 treatment, because this trial was pretty large. Now, there is some disagreement. This trial was not necessarily designed to optimize remdesivir use in terms of making it work most effectively. So some of the folks involved said, well, maybe if they designed the trial a little differently, they would have seen more of an effect. But the big takeaway here is that the stronger the efficacy, the more effective a drug is, the easier it is to see in a clinical trial, just because of the way the statistics work. That the bigger the effect, the easier it is that pops out and stands to people get better. If remdesivir is effective under some conditions, clearly it's not the panacea. It's not going to be a cure for the majority of people that take it. And so maybe it could be slightly effective given the other trials that were conducted with slightly different clinical trial designs, but it's not going to be a panacea. And if you're wondering, we've been calling it remdesivir. The brand name now is Veklury. Some people might be referring to it going forward. But yeah, it's not, I mean, if I were to get sick or someone I cared about got sick, would I want them to take remdesivir? Yeah, most likely. But is it going to be the panacea? Almost certainly not. In fact, that's an interesting question. Someone was asking me. So if a parent of mine or a friend who was at high risk got sick, what would I want them to do? So the first thing I would want them to do is, one of the things that we just saw is that the earlier they get treated and they start getting seen by a physician or in the hospital, the better. So at the very, very, very first sign of a symptom that could be related to COVID-19, immediately use that as a trigger to go and get a COVID-19 test, go to the physician, or go to, depending on the severity of the disease, immediately go to the emergency room or the hospital. I mean, if you have COVID-19 symptoms, you're a high-risk person, you need to get yourself in front of a caregiver to be further assessed. As the months start going by over the winter, the fall and winter, I mean, we don't want to overload the emergency rooms either, but if your symptoms are starting to get even a little bit severe, do not hesitate, because the earlier you get on oxygen and are seen, even oxygen itself can be very helpful. Second, remdesivir is available. The earlier you get on remdesivir, it's an infusion, so you need to be in a clinic or a hospital in order to get it. If it's going to work at all, you need to get it as soon as possible, because if you wait a couple of days, then there's less efficacy. And so that might be one of the reasons why the World Health Organization had a smaller effect in terms of their clinical trials, because some of the people might have delayed before when they got on the remdesivir treatment. And then third, so we know some of these additional drugs out there, the monoclonal antibodies or the polyclonal antibodies are being developed by a few different companies out there at this point. Those were the miracle drugs, as President Trump said, that he was given on the first day that he got symptoms. And so that's not readily available outside the context of a clinical trial. So if the second you get symptoms, I would do everything you can to get in one of those clinical trials right now. You won't necessarily get the treatment, but at least you'd have a fair shot of getting the treatment. And that would be what I would do. So between those three things, one, self-identify as quickly as you can. Do not hesitate and say, oh, I'll just see what happens in the next few days. COVID-19 is spreading like crazy. And if you get COVID-19 symptoms, flu is not spreading crazy right now. If you get COVID-19 symptoms, you most likely still have COVID-19 as the thing that's driving your symptoms. So don't hesitate. And then two, remdesivir, it's available. The earlier you get it, if it's effective at all, the earlier the better. And then three, get into a clinical trial. I still think at this point, some of these drugs are very likely to be effective. We don't know yet. That's the safety and efficacy are still being figured out, but at least for the polyclonal antibodies, the best scientific minds and best physicians in the country who decided on the course of treatment for President Trump, that's what he got. Whether it was fair for him to get it or not, it's a different ethical question, but get on the clinical trial if you can, and that's what I would do.
So Glenn, thanks for taking us through that. So Rachel has a question about the potential harmful effects of remdesivir. So if it's unclear that it's so going to be our panacea and so helpful, what are some of the harmful potential effects?
Yeah, so I don't know in particular. What I did see was that the side effects of remdesivir were roughly equal to the same quantity of side effects in the placebo group, which means that it was so the remdesivir itself seemed like it was very safe. And so it was, and the question is whether it had efficacy or not. So unlike hydroxychloroquine, which caused heart murmurs and caused problems with the rhythm of the heart, I don't think that there's been anything identified with remdesivir. If, God forbid, someone you know or someone at high risk is diagnosed, then I would look into it more closely at that point. Ask your physician and fully understand the trade-offs and the balance in terms of the safety and efficacy before you take the drug.
Great, thank you. So a question has come in about diabetes. We know that diabetes is a risk factor for COVID-19, but can COVID-19 trigger diabetes in otherwise healthy people?
Yeah, this is a really interesting question. And so it goes back to this bigger idea that SARS-CoV-2 is doing all sorts of crazy things to the body that we don't even fully know what it's doing yet. This ACE2 receptor is located almost throughout the body, organ systems throughout the body. And one of the places that it's located is the pancreas. And the pancreas is where insulin is made. And so people who get problems with their pancreas, that's where diabetes, it's one of the, on the causal pathway of diabetes. And so previously we knew that people who had diabetes were at greater risk of severity from COVID-19 if they were infected with SARS-CoV-2. But now it seems like it may be birelational. So it might go both ways, where if someone's infected with SARS-CoV-2 and gets COVID-19, that might increase the risk that they have problems with their pancreas and become diabetic. There have been some instances where people got COVID-19 and then had symptoms of diabetes. We don't know if the diabetes will go away once the COVID-19 goes away, if the pancreas will heal itself. We don't know this yet. It's just starting to be studied. We don't even know if it's a real effect. This was published in the New England Journal of Medicine, a prestigious medical journal. But we don't have major clinical trial or major epidemiologic trials that have been investigating this yet. And so it's still an unknown. And there could be a couple different pathways. So for instance, it could be that there's something about a SARS-CoV-2 infection in the pancreas, in the ACE2 receptor there, that's doing something in the pancreas that might be triggering diabetes. Or it could be that there's something about the immune system that's triggering an immune response, and then it's almost like an autoimmune response that's attacking the pancreas. There's two different types of diabetes. There's type 1 diabetes and type 2 diabetes. Type 2 diabetes is typically seen as sometimes called adult onset, although it's not necessarily just in adults, but it's more people who tend to be overweight, and then they have metabolic syndrome, and then it causes the overload of the pancreas having to work so hard that it causes diabetes eventually, because the pancreas just has trouble. Whereas in type 1 diabetes, where among people who are born with it or get it very young, that's typically an autoimmune disease where the body is attacking the pancreas directly. And so we don't even know if this signal is real. Like I would say it's mostly a hypothesis now, where some physicians have sort of been identifying it and saying this is something we need to be tracking and paying attention to. But it is something that a lot of people are focusing on. That it seems like it could be a concern that we need to be paying attention to. And it's one of these things. This goes back to this we've talked about previously. The herd going to the herd immunity. That this idea of natural herd immunity might be a way to end this pandemic. But the problem is that this is something that is not something we want to encourage in the population, to suddenly have a lot more cases of diabetes and people at severe risk for health. So back to you.
Thanks for clearing that up a bit. So it sounds like more to come. How about the long haulers that they're sometimes called, the people who with COVID-19 who have symptoms that persist for weeks and even months? Do we know any more about some of these kinds of cases?
So this, for me, I think this should be a major area of research. It's surprising to me that we know so little at this point. It's already the end of October, and this should have been one of the major areas of research that people have been looking at. So there have been some studies that have been done. I like this review done by the National Institutes for Health Research in the United Kingdom. But the studies that were done were small, so I don't put a lot of weight into any one of them. But it's interesting that the story has been somewhat consistent across the studies, even though they're small. But again, it's really early. We should have had major investment in looking at the long-term consequences of this disease. And the primary reason being that we're still having this national conversation about whether to pursue natural herd immunity. And the fact is, if there are a lot of people who have SARS-CoV-2 for long periods of time, then that would help in that conversation. And unfortunately, the same countries that have been promoting natural herd immunity have specifically generally not been investing in these studies to identify the long-term consequences of SARS-CoV-2. But here's some studies that were published. One study in Italy reported that 87% of people discharged were still experiencing at least one symptom 2 months after they first got infected. 55% had 3 or more symptoms, including fatigue, difficulty in breathing, joint pain, or chest pain, with 40% saying it had reduced the quality of their life 2 months after infection. And so at that point, it's not going to suddenly stop the day after 2 months is over. There's a long, deep curve there for healing to occur. And we don't know how long that healing curve takes. The next thing is over here. And this, I've seen this number in a few different places at this point. So the Public Health England organization published guidance based on their best understanding that around 10% of mild COVID-19 cases. So again, people who are mild, this is not people who are hospitalized. It's not the severe, it's not the moderate. These are the mild cases. 10% of them reported to have symptoms lasting over a month. So mild symptoms, but lasting over a month. And among hospitalized cases, reported that the amount of symptoms, again, lasted 2 months or more following discharge. In this other study, this was looking in the US. Oh, so there were 2 studies here. One was self-report, so it was just a survey. But interesting, in this survey of people who are these long haulers, the vast majority of participants experienced fluctuations in the type of symptoms that they had and the intensity of the symptoms. So there were 2 things that they found. So this was very common among people who had symptoms for, let's say, a month or more and were considered the long haulers. One, it could be that their symptoms started out with one thing, like maybe their symptoms started out with coughing, but then over time it shifted to something else, like maybe gastrointestinal systems or other parts of the body that the ACE2 receptor was involved in. And so the shifting of symptoms was something that was interesting and shifting over time. The other thing was the intensity, where for a lot of people in terms of these long haulers, what they're reporting is it's not constant. There's good days and bad days. There's good weeks and bad weeks in terms of when the symptoms come up and when they start to go down, and then people start feeling ill again. And so it's tough in terms of looking at that. The other thing, there's this app in the United Kingdom, this I don't know if it was an iPhone app or like a phone app, but they had 4 million regular contributors who were tracking their experience with COVID-19. And it suggests that a significant number of people report symptoms for a month, and between 10 to 20% report complications for longer than a month. So 10 to 20% is a large number. When we're talking about millions of people being infected at this point, we're talking about large numbers of people. And if we go into this winter, so that in the Northern Hemisphere, as we go into the winter, and that can easily double or maybe triple in terms of the number of people that are infected, this long term, this percentage of people who continue symptoms for months after could get really high. And so then when we're looking at the total cost of the disease in terms of morbidity, in terms of the actual financial cost, in terms of people being able to go back to work after they get sick if they have these symptoms, and potentially death, because we don't know among these 10 or 20% who report complications, are they at increased risk for fatality in the month or 2 months or 3 months after they've had the initial infection? We don't know this yet. It's still, I wish that our governments had been investing money to study this better, but these are critical questions. We still don't have the answer to them yet.
Well, we're very lucky you're bringing us this research from around the world, because I guess there is one benefit of us, going through this kind of all simultaneously, right? Even though we're a couple weeks behind, I guess, is pretty much the case, that we can really learn.
Not anymore.
Really not anymore.
We're the world leader now. The United States is leading edge.
But as far as kinds of like I guess we're in the lead, but the wave, we were pretty much 2 weeks behind.
Yeah. The key thing is that, like, when you look at North Dakota and South Dakota, our numbers are higher. It's just we've had our peaks at different places. Other parts like Europe and other parts of the world are now starting to increase rapidly. And the only reason it appears that the United States is not is because we still have a bunch of states that are doing well. And so the denominator, the average at the US average doesn't look as bad. But if you look at specific states within the US, we're among the worst in the world. If these were countries, we'd be among the worst countries in the world.
Oh my goodness. Well, we are almost out of our time together, so we're going to wrap up with a couple questions. First, Sandy has a question about the various organ systems that the virus impacts and how that compares to other viruses. And then we're going to wrap up with the question about, can mouthwash prevent the spread of SARS-CoV-2? So Sandy, I'm going to ask you to unmute, and you're unmuted.
Thank you, Beck. Glenn, polio was really a muscular disease, and I really don't know a lot about a lot of the viruses that have been around, but the Spanish flu, I don't think affected the number of organs. Since you've started your talks, you've talked about hormonal impact, you've talked about clotting, you've talked about heart. We certainly knew about lungs early on. People have lost, I guess it's vascular, they've lost limbs. I'm not sure, now the pancreas, I'm not sure that I've ever known, not that I would know, of many other coronaviruses or novel viruses that have attacked so much of a person's body.
So viruses are very specific. So the flu virus attacks the skin cells, so epithelial cells in the lungs and the respiratory tract. And so it attaches to very specific types of cells, and they gain entry in very specific ways. It's surgical precision usually. So for instance, the hepatitis virus is very specific to the liver. And so viruses affect very specific things, like the nervous system or very specific areas. The coronavirus, one of the things that makes it unique is that it attaches to this ACE2 receptor. And so the influenza, the other viruses don't use this receptor. And so because this is the key receptor, then any cell that has this receptor anywhere in the country is potentially at risk from the virus. And this ACE2 receptor occurs all over the place in the body. That's one of the reasons that we're seeing symptoms everywhere. And so when we're looking at things, there's a lot that I haven't even talked about over the weeks very much. Kidneys, so immune system. I mean, we know that there's immune system effects, but the immune system itself can actually be infected. We've talked about the immune system as just a response to the virus in other organs, but the immune system itself can be infected potentially. And so all throughout the body, the ACE2 receptor is very common. And so that means that there's lots of symptoms that haven't even been reported very well yet. Because the pancreas wasn't even one on this original list that I had here. But the ACE2 receptor is found in cells and organ systems throughout the body. Again, it's because it's the ACE2 receptor. That's what differentiates it. Viruses are very specific to different cells. That's how they get into the body in different ways. So, Rebecca, back to you.
Thank you. Great question, Glenn. Thanks for taking us through that. So to wrap up the evening, can we talk about mouthwash? What questions come in? Can mouthwash prevent the spread of SARS-CoV-2?
Yeah, so the short answer is no. So basically, or not yet. Basically, in a petri dish or in a non-clinical situation, it was found that if you use very, very dilute baby shampoo as a nasal rinse, it'll deactivate SARS-CoV-2 or human coronavirus in general, let's say. And that if you use Listerine or other mouthwashes and gargle for 30 seconds, that right after the 30 seconds is done, that it deactivates the virus. But there have been no clinical trials or anything like that. And there wouldn't be no reason to believe that gargling with Listerine would eliminate the virus from the body. Instead, it could eliminate it from your mouth for a few seconds or so. But if you have active infection in your body, within minutes or hours, your body is going to be still producing virus as the new cells break apart, and you're not going to be gargling with Listerine every minute of the day. And so as a therapeutic, it's almost certain that mouthwashes cannot protect the spread of the virus, just because you need to be doing it literally like every minute of every day, and that's not feasible. But it's one of these things. A lot of studies have been coming out that have been showing things like this, like in a petri dish or in sort of non-feasible ways, just to see if it is effective. But then when you think about it as an epidemiologist, like in the real world, could it actually be an intervention that works? It's just not feasible for something like this to work.
Well, thanks for clearing up that one. We were hoping that would be the good news of the evening. Not your fault. Any good dog stories? We haven't had one of those in a while.
Yeah, no dog stories.
The dogs being able to sniff the virus, huh? All right. Well, maybe next week we'll have a good dog story. But we do appreciate the news, even if it's not what we're hoping for. It's better that we're informed than not, right? So thank you everyone for being here tonight. Glenn, thank you for digesting all the news for us and displaying it in such a clear way. That's so helpful. And hope everybody has a very, very safe and happy week. And I hope we get to see you again next Sunday. Same time, same place.
Sounds great. Have a great week. Bye-bye.
Bye-bye.